Our final speaker for the morning follows appropriately on the heels of David's talk. Nita Seibel. Nita Seibel is a. Oops.
Sorry.
Okay. You're all set. That was the bell. Yeah. Nita Seibel has been well known to all of us in pediatric oncology through her work at the National Children's Hospital and George Washington University in Washington, D.C., but which she joined the faculty in 1988 and worked in a variety of leadership capacities, including being the principal investigator for that institution, the Children's Oncology Group that you've heard about so much today. But in 2008, she came back to the National Cancer Institute, where she, as a senior investigator in the clinical investigations branch of the Cancer Therapy Evolution Program for the Division of Cancer Treatment and Diagnosis. This is the program that really oversees our coordinated translational trials, clinical trials in cancer, and it's really been a great fortune of all of us and for the AYA program that she was positioned there in this capacity when the efforts to develop an AYA program came along. And there she was, ready to go. And her contribution to this field has been very significant in really bringing together our discussions about the biology of cancer, the nature of cancer, the research that we need to do in cancer, both at the basic level and at the translational level and at the clinical level. And she has been a leader in serving as the co-chair of the Trans NCI Adolescent Young Adult Oncology Working Group, and was the person who really helped to bring together the 2009 NCI Young Adult Oncology Science meeting. I'm sure she's going to refer to this in her discussion. So without further ado, Dr. Nita Seibel.
Well, good morning. I know the position of being the barrier between lunch, so I'll try to keep that in mind as I talk about particularly how the NCI is playing a role in the adolescent and young adult oncology sort of pursuit here, and particularly the workshop, which you've heard a lot about. So I'm going to give you sort of a brief overview of what happened, and these will be preliminary sort of recommendations because they haven't been finalized yet. The working groups are still working on it. And then I want to focus a bit more on the biological aspects, particularly as it relates to the workshop as well, and then to finish up talking about the clinical trials and the relationship to CTEP and what's coming ahead. Ooh, let's try this. So just to give you an overview of what has occurred since 2005 and 2006, one of the initial sort of like milestones was the publication, or first it was the progress review group and the publication of those results and recommendation, and then it was followed by the monograph, the SEER monograph, and then the AYA HOPE study, which Brad has already mentioned, and that stands for health outcomes and patient experience. As a result of that study, there have been 8 published manuscripts and 9 more that are in progress. The Patterns of Care study is another one that has also come out of the NCI and out of the PRG as well, looking at patterns of care of how AYA patients were treated within the community, and there have been at least one publication, and there are several more in manuscript form related to this. Stu mentioned the Trans NCI AYA Working Group, which I co-chair with Ashley Smith, and every year along with the Office of Communications at the NCI, a snapshot is produced of AYAO Oncology and what's been going on, and sort of an update of the statistics. And then the patient portal, or AYAO Oncology portal, has been developed through the NCI that provides information for AYAO Oncology patients, particularly related to clinical trials and other resources. And then in 2009, Stu mentioned the biology workshop, and this was to really look at the differences in biology for 3 specific tumors, that of colon cancer, as well as acute lymphoblastic leukemia and breast cancer, when they occur in the AYA population as compared in the case of ALL to the younger population, or in colon cancer and breast cancer when they compare to when they occur in adults. And so that took place in 2009, and those findings were published in the Journal of the National Cancer Institute in 2011. And then most recently, one of the cancer bulletins had a specific issue focusing on AYAO Oncology. So this brings us to the workshop that you've heard about. Here are some pictures from the workshop. This was in September, on September 16th and 17th in Bethesda, and this was the next steps for adolescent and young adult oncology, and it was a scientific update. And the working group chairs, which are listed there, many of them are here today, are really were the key to this workshop. And I can't tell you how their dedication and their prioritization of how important this is and the time that they gave in planning this workshop, and they're continuing to put in for the recommendations. I have the privilege of sort of describing the results of this workshop, but they're the ones who did the work along with the working group members. So just to give you an idea of how it was organized, the purpose of this workshop was to review and discuss the current research and gaps in research in AYAO Oncology, and across 5 specific areas. And unfortunately, we would have liked to have extended it, particularly into the area of AYAO Oncology survivorship, but we had to narrow it down for the amount of time that we were going to be spending. And so this included epidemiology, basic biology, clinical trials, health services and medical care, and health-related quality of life. And when relevant, we wanted to look particularly at certain oncology diagnoses, and those included colon cancer, breast cancer, acute lymphoblastic leukemia, melanoma, and translocation-specific sarcomas. And the goals were to understand the current state of science in these areas and to identify fundamental challenges and gaps in the field, and then to frame the direction and ways forward for AYAO Oncology as we move forward in the future. How this was organized, that we developed a planning committee of the working group chairs, along with Ashley and myself, and we started about a year in advance, and we had monthly conferences developing the agenda and the questions, and then the individual working groups were set up as well. And within the working groups, there were subgroups organized actually to do literature searches and to really gather or do the research upon which they then analyze these results and are making recommendations. Prior to the meeting, each of the working groups provided a preliminary report which was circulated to everyone who was attending the workshop, and this was the basis for our discussion and recommendations that will be forthcoming. And as I mentioned, the recommendations that I'm going to be discussing or mentioning are preliminary at this point. Over the next month, they will be finalized and hopefully then be drafted into a manuscript. So one of the first items that we discussed at the workshop was the whole AYAO Oncology age range. Earlier it had been from 15 to 29, then it had been extended to 15 to 39, and it was discussed if this was the ideal age range or if we needed to narrow it. And the conclusion from all the participants at the workshop was that this was the range that we needed to work with, and this was an understudied group of patients, and particularly for consistency in comparison to other studies that were being done, that this range would be maintained. As you've heard today, there's challenges with this range, as Brad has mentioned, particularly the developmental variation, because it includes a broad range of ages and changes, and also differences in cancer sites that you see, particularly from the adolescent age range up to the older age range. But it all underscored the need to conduct research in these different age groups. So the first group was that of the Epidemiology Working Group, and Ann Geiger, along with Archie Blyer, led this group. And you can see all the members of the group are listed here, and we had broad representation from North America. And there were specific questions that the Planning Committee had drafted and were posed to the working group that they were going to address during the workshop. And so these questions are: what are the current incidence and mortality rates for AYA cancers? Has there been a change over the past 2 decades? What are the survival rates? Are there different or additional cancer types occurring in AYAs that should be prioritized? And are there new data sources or analytic approaches that should shed light on the epidemiology of AYA cancers? Briefly, what they presented is that in breast cancer, there's no noticeable change in the incidence. There is a decrease in mortality in this age group. In melanoma, there's a decrease somewhat in the incidence, but no noticeable trend in the mortality there, and we'll talk about that a bit more. In colorectal, there's actually an increase within the AYA population and no significant change in trends for mortality. There are differences by sex and race. In leukemia, the incidence is increasing in the AYA age group. However, the mortality is decreasing, particularly by sex. And then in the translocation positive sarcomas, there's no pattern that could be identified with the incidence, and the mortality was really not able to be examined. Their conclusions or recommendations are that incidence and mortality rates increase with age, but it's a complex pattern by race and sex and ethnicity, that additional resources or data sources are needed, and so they need to leverage the existing study and plans, but identify new sources as well. And they recommended repeating the pattern of care study, particularly in the current environment. They also suggested the need to incorporate biological and environmental factors and shift from primarily biological factors and to look at environmental causes that could be contributing to the occurrence of certain malignancies in the AYA age range, and with the potential or possibility of preventing some of these. And then analyses by anatomical site, stage, and or biological characteristics should be done in these areas. Now, to move to the next working group was the Health Services Working Group, and Karen Albritton and Brandon Hayes-Latin chaired this working group, and you can see here again that had a very broad representation. And the questions that they were challenged with were: what healthcare models are ideal for meeting the needs of AYAs with cancer? What does research show about the quality of care and economic burden in this population? Have there been changes in practice based on research for AYA health services and medical care? And if so, what are the changes? And what are the priorities for research in AYA oncology health services? What they found is that the health services research on AYA is lacking, that they underscored the need for appropriate metrics and study designs to examine the receipt of quality care. There are little data on cost to patient, even less on costs to the healthcare system. AYA oncology clinical programs exist, as you've heard about, but they have inconsistent components and in some cases are not evidence-based. And it's not clear if the location of care matters, if it's at a pediatric institution versus a cancer site-based, or is it more important that the physicians who are involved are well represented and multidisciplinary. And their recommendations are to determine where AYAs are being treated by age, by disease site, and to determine the components in the receipt of optimal cancer-directed therapy by site, to develop studies to better examine delays in diagnosis in AYA oncology patients, to measure patient adherence and validate the impact it has on outcome, and to examine the impacts on health insurance, particularly the Affordable Care Act. Now, the fourth working group was the Health-Related Quality of Life Working Group, and this was chaired by Brad Zebrak and Lynn Wagner, and all the members of their group are shown here. And their questions were, what new knowledge and improvements have there been in health-related quality of life and symptom reports in the past decade? What do we know about the symptom burden for AYA oncology patients? What are the validated measurement tools in this area, and how adequate are these tools? Are there additional tools that should be developed and validated for research investigation in this group of patients? And what are the recruitment challenges and implication for quality of life and survivorship studies in these patients? And their group did a very extensive literature search. They divided into subgroups, and depending on the subgroup, the articles that they identified ranged anywhere from 154 to over 500, and these dealt with specific domains of physical, psychosocial, spiritual, and methodology domains. They found, and they reported, that AYAs have challenges in areas of physical function, activity, fatigue, pain, comorbidities, health behavior, as well as psychiatric symptoms, benefit finding, growth, coping, identity, developmental tasks, sexuality, and peer relations. Also, the issues relating to social normalcy, network stigma, work with school, socioeconomic status and relationships, and reports of uncertainty, hope, and gratitude all were identified. And they recommended the need for additional research in these areas, particularly as it relates to symptoms, risk and resilient factors, family distress, impact. Much of this you've heard about already. Brad reported on sexual function, body image, financial well-being, spirituality, faith and practice, and how more rigorously designed studies with better instrumentation, understanding of different subgroups, are there health disparities within the groups, cancer types, and age group, and to use existing data to develop ultimately interventions. Now to switch to the biology working group. And this group had a different structure somewhat because they were focused on particularly 5 diseases: colon cancer, breast cancer, melanoma, translocation-positive sarcomas, and ALL. And this group was chaired by Jim Tricoli and Don Blair from the NCI. And this slide appeared in Science and is a picture of a young woman who 19 years of age with ALL. And the question that comes up, if she had been diagnosed 10 years earlier, her outcome would have been so drastically different, whereas she probably would have been cured of her ALL, whereas that's not the case at 19 or in the adolescent and young adulthood range. And why is it? And this is not unique to ALL, as David has mentioned already. Although in this slide, you can see how the age range makes a big difference in that those patients, the overall outcome decreases with increasing age. But this is also true in Ewing's sarcoma, as David has mentioned. Particularly, why does a patient less than 10 years of age have a 70% event-free survival versus someone between 10 to 18 or 10 to 17 years of age where it's 60%, and then older than 18 where it's around 40 or 45%. It's true in other tumors as well, and even some that are not seen very frequently in adults at all, such as neuroblastoma and Wilms, that the adolescent and young adults have a poorer outcome. So the questions that the biology group worked with were, for which AYA cancers have we made progress in the understanding of the biology in this age group, and what ones are still lacking? Do we have data on any which support a difference from the same disease occurring in a younger or older age group? And do AYA patients metabolize drugs differently than adults, or are they unique in their metabolism and associated toxicities? So to start out with colon cancer in the AYA group comprises 2 to 6% of all the colon cancer cases reported each year. And there's approximately 800 deaths annually. There's certain predisposing factors that have been identified, particularly hereditary conditions, inflammatory bowel disease, and prior radiation exposure to the development of colon cancer in the AYA age range. They tend to have a poorer prognosis and have a more aggressive disease than what's seen in older adults. And there are certain findings histologically that are evident in this age group. Particularly, they tend to have more of a mucinous signet ring histology, microsatellite instability is high, and there's mutations in the mismatch repair genes. There's also a lower frequency of some molecular findings in AYA patients with colon cancer as compared to adults, particularly in the number of KRAS mutations in 17P and 18Q-LOH. There's a lower P53 protein level found in AYA patients as compared to older adult patients. However, the use of combination chemotherapy improves the overall outcome in AYA patients, and the response rates with AYA patients when treated with combination chemotherapy is similar to that of adults. Also, the location of where colon cancer develops in AYA patients, 50% of the time it will occur on the right side of the colon, whereas in older adults it tends to occur on the left side. Now, to get a handle on colon cancer, there is a molecular study that is being done right now by Jim Tricoli looking at colon cancer, probably the largest number of colon cancer specimens for AYA patients, and they're looking at the somatic mutation rate within the AYA population by whole exome sequencing, and they're going to compare this to older adults. So we'll have a better grasp on that, and we expect those results to be out within the next 6 months. Now to switch to breast cancer, and you can see how how breast cancer incidence increases with increasing age. And you can see for the AYA population, it makes up about 6.6%, or about 13,000 cases per year in women less than 40 years of age. What do we know about breast cancer in this age group? Well, breast cancer is the most frequent cancer in women in the AYA population. It occurs in about 1 out of 200 AYA women will develop breast cancer. It's the leading cause of cancer deaths in women between 20 to 39 years of age. And the disease is more likely to be aggressive and to exhibit a triple-negative basal cell phenotype when it occurs in AYA women. It often presents at a higher grade with a poorer prognosis. There's a higher rate of lymphoblastic invasion in AYA women, and there are molecular studies that suggest a novel gene expression to the breast cancer pattern, or the breast cancer when it occurs in an AYA females. However, this is somewhat controversial. What do we know about the molecular characterization of breast cancer in AYA females? Well, they've identified differential gene expression studies, but identifying a unique pattern, but in comparison to older women. However, these results there's some conflict between these results, so it hasn't been established. There also is a suggestion of an association between germline P53 mutations and early onset of HER2-positive breast cancer, which could give some insight into the molecular pathway that's involved in breast cancer. And then BRCA mutations have been linked to susceptibility and early onset of breast cancer in this age group as well. So now to switch to melanoma. Melanoma is the third most common cancer diagnosed and the most lethal form of skin cancer among AYA patients in the U.S. The 5-year overall survival is 65% for patients who present with regional disease, as compared to 15% for those who present with metastatic disease. It's higher, it occurs more frequently in females as compared to males, and we tend to see more cases of the trunk in this age group than in the older age group. What else do we know about the risk factors for melanoma with AYA patients? Well, adolescents and young adults appear to be particularly at risk for developing melanoma because of the UV exposure early in life. There are other settings or risk factors, particularly in the setting of giant congenital nevi, neurocutaneous melanosis, xeroderma pigmentosa, Werner syndrome, retinoblastoma, and immunosuppression that all make them more likely, if they have a history of this, to develop melanoma. Also, if they've undergone a transplant or chemotherapy, that increases their risk of melanoma. And adolescents tend to have a higher number of melanocytic nevi, particularly the larger size, that's related to it. Also, fair complexion, facial freckling, and a family history of melanoma increases their risks. And it's important to understand the risks within AYA, the development of melanoma, in case there are activities or targeting prevention strategies. This was a recent study that just came out, and actually it was done by a group from Stanford, looking at or identifying that for white, non-Hispanic males, they have a survival disadvantage with melanoma, and this is for young adult males in the age range of 15 to 39. And as you can see, that compared to females, the males have a lower survival, and actually they're 55% more likely to die than age-matched female controls. And that's shown on the left. And then and the other one shows, despite the extent of spread, localized disease versus metastatic disease, that young adolescent men are more likely to die from their melanoma than adolescent female and young adult females with melanoma. So the biopathology of melanoma in adolescents and young adults is under investigation, although probably not enough is being done. And it's somewhat controversial because there's a need to distinguish conventional melanoma from a subgroup of melanocytic neoplasms, particularly the Spitz-Nevis-like neoplasms. And what they found that the outcome with melanoma, interestingly, as compared to older patients, in AYA patients, they have a tendency to metastasize to the sentinel lymph node. So it's more likely for the lymph node to be involved with patients with melanoma than in the older patients. There have been genomic hybridization studies been done to be able to identify and differentiate melanoma from the Spitz nevi, which are ongoing, and more need to be done in this area, particularly with some of the genes. And then to switch now to the translocation positive sarcomas. And this slide shows, in comparison to children, the 15 to 19-year-olds, and they're shown in that mustard colored. And you can see the improvements, particularly with osteosarcoma, Ewing's, and rhabdo in the younger patients, but there have been some improvements in the 15 to 19-year-olds, but they're definitely not at the same level as what we've seen in the younger patients, and particularly you can see that they've somewhat plateaued. This is a slide that shows the whole spectrum of translocation positive sarcomas, and it just really to show you the diversity of this whole group. And some of the challenges are particularly being able to identify with the fusion genes, how to target the fusion genes, and how this interacts with the biology of these sarcomas. One of the key factors to realize that they're doing studies on these sarcomas, and out of over 3,000 tumor samples that have been sequenced, none of them have been from AYA sarcomas. And so this really underscores what we've talked about already today, the need to get tumor tissue to identify this. Also, this shows some of the work that's being done at the NCI to really identify how we can target these fusion transcripts. And here are some of the other approaches that are being taken right now in sarcomas, particularly as it relates to treatment. This is currently one of the studies that's being done, and anyone can participate in this study. Javed Khan at the NCI is doing genomic sequencing of tumor tissue, and tumor tissue can be sent to him along with germline tissue in order to get a better handle on the sarcomas that occur in AYA patients. This just shows and presents part of the problem with sarcomas, particularly right now, and that is with the pediatric ones. You can see that are over here on the right, the low number of mutations that have been identified, particularly as you compare it to other cancers that are seen in adults. And we don't know where AYA population, where the tumor tissues fit into this whole spectrum. But the problem is, if you don't have the mutations or targets, you're not going to be able to target them with your therapy. So just to finish up now by talking about acute lymphoblastic leukemia, and this is probably the area where we know the most from the biological standpoint. It's the most common cancer from birth to 21 years of age. It's the leading cause of mortality in AYA patients. The incidence is increasing, as you can see right here, and the outcome remains poor in this age group, with less than 45% achieving a long-term remission. And survival from ALL decreases dramatically after puberty, and it's understudied, particularly the contributions of race and ethnicity. This shows the changes that have come about, particularly with pediatric ALL, as less than 15 years of age. And then for the 15 to 19 years of age, you can see most recently there have been improvements, particularly in the last 4 or 5 years. This is a slide that many of you are familiar with that shows the cytogenetic translocations that we see with ALL. And what you can appreciate is that particularly the good risk ones are much more common in the younger age group, but the higher risk ones are the ones that suggest a poor prognosis increase with increasing age, such as the Philadelphia chromosome, the 922, and you can see how that increases with increasing age. So many cases of ALL, when they relapse, lack the known high-risk chromosomal rearrangements. So it's hard to identify those high-risk ALL cases at the time of diagnosis. In Philadelphia chromosome positivity is about 3% in children with ALL. It's about 25% in young adults ALL. And it's been shown by Kurt Schultz, by combining chemotherapy with a tyrosine kinase inhibitor, you can improve their outcome. There's another group, and this is very exciting right now because, and much more will be coming out about this, what's called a BCR-ABL-like group. So this is a group of high-risk ALL that has a poor outcome, but they can't find the 922 translocation. But they behave very similarly and have a poor prognosis. They also know that this group has a high percentage of deletion of the Ikaros gene. It makes up about 10 to 15% of ALL, but there's a higher frequency in AYA patients. And this is associated with poor outcome. About half of them will have a CRLF2 alterations. Many of them will have JAK mutations, and then there's other mutations they're finding as well. Rearrangements seem to activate some of the pathways, particularly that tyrosine kinases can sort of attack or inhibit, and they've also found RAS mutations. Next month at the American Society of Hematology meeting, Cheryl Willman and Charles Mulligan will be reporting their data. They have about 17 ALL specimens from AYA patients, and they'll be providing much more insight into the molecular pathogenesis and particularly the possibility of targeting some of these. So this is very exciting because, and again, underscores how important it is to get these tumor samples, and these tumor samples were collected because of intergroup collaboration between the cooperative groups.
You said 17. What's the total number they have?
They have 700. 700, sorry. So the recommendation, just to summarize here, particularly is to obtain the tissue. So specific questions can be addressed, and then action items can be formed from scientific data, and and again to underscore the need for annotated tissue resources. The clinical trials working group, I'm really not going to say much about, except to show this slide, which graphically shows, this was a study that we did at the NCI in preparation for the workshop to look at the involvement of AYA oncology patients in the NCI-sponsored clinical trials. These were limited to newly diagnosed patients, and the limitation of looking at this is you have to have a trial available to be able to look to see what the participation was for the AYA population. As you can see here, and this was divided between 15 to 19 years old and 20 to up to 39 years of age, the trials that had the highest percentage of AYA participation were that of ALL, AML, particularly in the 15 to 19-year-olds, and then Hodgkin's, as well as bone tumors and cervical cancer. Now, particularly for Hodgkin's, it's not surprising since Hodgkin's really is most common in this age group. So the recommendations David has already talked about, and just to mention one more thing before closing, and that is the re-engineering or restructuring of the cooperative group system. And as you can see up here on the top, the 10 different cooperative groups that used to form the cooperative group system have now been changed and have merged together to increase the efficiency, to provide stronger scientific trials, and to increase enrollment into the trials into 4 adult groups, which are shown down here, with 1 pediatric group. And the other point from this slide that I wanted to make is that over to the side you see the CTSU, and this stands for the Clinical Trials Support Unit. This was developed to support the cooperative group trials. And what it does is that when a trial is posted on the CTSU, any member or investigator of one of the other cooperative groups can enroll a patient on that trial. So that means in the trials that David mentioned that would expand the AYA population, they will be on the CTSU. So if an investigator from SWOG, even though they're not part of that trial, has a patient who's eligible for that trial, they can enroll the patient on the trial. So as you can see, for AYA patients, there will be a much broader ability to enroll patients onto a relevant trial. In addition, you see the NCI Central IRB. So any trial that's posted on the Clinical Trials Support Unit is already approved by the IRB. There's a pediatric Central IRB and there's an adult IRB. When we have a trial that spans the AYA age range, we have experts on the Central IRB to review it. So if it's reviewed by the adult Central IRB, it will be approved, and it will be taken as being approved for the pediatric side as well. It works the same way. If a pediatric IRB, or if a COG trial goes through the pediatric IRB, there'll be adult representatives on it, and so once the pediatric IRB approves it, then it's approved for all adult groups as well. So once it's on the CTSU, that trial is ready to be downloaded and activated at the institutional level. As part of the NCTN, as of March, all cooperative group investigators need to be part of the Central IRB or have a waiver. So there are just several other studies that are targeted to go on the CTSU and will span the AYA group. The Ewing study, there's currently a localized Ewing study that's on there right now that is supported also by RTOG. And then the non-rhabdo soft tissue sarcoma, David already mentioned. There's a desmoid study that we hope to, that the Alliance is sponsoring, that we hope to include for AYA patients. And then the metastatic Ewing study will go on the CTSU as well to provide greater access. So where are we going? with all this information? Well, one of the next milestones is the opening of the NCTN, which is in March of 2014. This will be followed by the results of the biology study, particularly from the colon cancer, as well as Cheryl Willman and Charles Mulligan, their results in ALL, and hopefully from those results that will motivate or stimulate further collaboration on treatment design in specific groups, publication of the workshop results, and then each of the working groups plans to publish additional manuscripts of their work that they did in preparation for the workshop. So we hope that once the recommendations are released, as well as additional information that's published, that this will stimulate more research in these areas. And then lastly, intergroup collaboration, not only between the cooperative groups, but the whole public-private collaboration, because this workshop and much of the work that's been done couldn't have happened without the help of particularly Livestrong. And that's a key component in the future as we go forward. So thank you very much.